And welcome to the Dr. Bob Show. Have you ever had that feeling of lightheadedness? Say you're dizzy, giddy. What do those words mean? Do you have vertigo? Does the room spin? Do you feel lightheaded when you stand up? We'll be spending most of this show talking about what people mean by lightheadedness and giddiness, and what are the causes of that and what we can do about it. My guest is Dr. Norm Walton. Dr. Walton is a board-certified neurologist, spends a great deal of time teaching at the University of Tennessee Medical Center, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about how the immune system is involved in attacking cancers and may prevent us from getting cancers. And red blood cells. Why do we have them? What do they do? And what happens when they go wrong? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Norm Walton, board-certified neurologist, and we're going to be talking about a peculiar, giddy, lightheaded feeling in the head. Norm, welcome to the Dr. Bob Show.
Thank you. Glad to be here.
When a person comes in and says, I feel sort of dizzy, what comes to your mind? What do you do?
The first thing I do is to really listen to what their experience is, because when somebody says dizzy, that actually means very little. And what you really have to sort out is exactly what they're experiencing and what their perception is. From experience, we know that most people are implying one of four things, but there can be plenty of other things too. One is a sense of lightheadedness, and that frequently is going to be positional. So I'm going to be listening to that history. Are you lightheaded? Feel faint, or that you may pass out, something of that nature. The second one is a sensation of spinning, which is going to be vertigo, and then that has a special reference for myself as well as ENT physicians. The third symptom is that of giddiness, and that's a term that you and I understand, but a lot of people don't. And giddiness is kind of this funny head feeling, sometimes a little maybe that they're rocking or swaying, or just that the head is doing something, but yet the body really isn't spinning per se. But it may be a symptom that's fairly persistent. And the other thing, especially in neurology, that we hear when people say they're dizzy, is that they really mean they have a gait imbalance. So as I listen to the story, I'm trying to sort out which of those four combinations it may be.
So let's start off with lightheadedness. When somebody says, I'm lightheaded, to me that sort of maybe means floating, but that could be giddiness, and it would not mean gait disturbance, or
Sure.
It wouldn't need vertigo. So lightheadedness, what do you think of?
Sure. So when I think of that, again, always gets back to the history. And so what I want to know is what provokes it. When does it come on? Is it a feeling anybody has while they're just lying in bed? Be very, very unusual from the point of view of that lightheadedness that I think of that could be on the basis of vascular. So I'm always looking and asking the person, and does it happen in the upright position? And specifically, does it happen after they stand up or while they're moving and moving around?
So if it happens when somebody first gets out of bed and they first stand up and they feel lightheaded, well, what are you thinking about?
One of the things that we're always thinking about is orthostasis. And what that means is that there's been a fluctuation of blood pressure and frequently their pulse when they're lying down compared to standing up. So our first thought is, okay, this could be orthostasis. Can we document it? So what we do then is going to be very important in the office is checking the blood pressure in different positions, lying, sitting, and standing. And we have criteria that we use of how much of a drop we tend to associate in order to say, this is orthostasis.
When I see people with these symptoms, a lot of times if you're talking with somebody, I ask them, when you have a cold, an upper respiratory infection and you first stand up, you feel like, what's going on that makes you feel, what vascular is happening that makes you feel that way?
I think at that time it's probably kind of a mixed bag sort of thing. There's a lot of people that when they have a upper respiratory infection, they may have some sort of vestibular component, but it's not of the type that we're probably going to end up discussing, of a labyrinthitis or of a vestibulopathy or that sort of thing.
These are sort of
but
things in
there's
the
still
inner
things
ear.
that are going on. And there's a lot of people who are just vulnerable and that they're more sensitive to being dizzy because, as we all know, you hyperventilate and you start breathing fast and you're anxious. We all have symptoms of a little unsteadiness, and people describe it in different sorts of terms.
Is it when people get hardening of the arteries? There's a carotid body in the neck that when people that adjusts blood pressure. I've always felt like it's when somebody gets out of bed, it takes that hardening of the artery and that carotid body a little while to adjust. How long do they, when they get up and they have orthostasis, how long does it take for that to adjust?
Yeah, it's really variable. And there's a group of people that we talk about have orthostatic intolerance. And what this means is that when they get up, they just don't tolerate that upright position. But we don't actually document that they became orthostatic with a low blood pressure. And it's variable from person to person. What you have to do, everybody gets very used to what's common for them. And there's little gimmicks that people can do, as crazy as it sounds. When you stand up but you bend over a little bit, squeeze your hand, that tends to activate the part of the nervous system, and the blood pressure may respond and get a little bit higher. There's a group of people that know that they maybe should have a drink of water or something before they get up. And there's a group that just has to understand that every time they do stand, they are going to feel that way. And that group, you make sure that if they're lying down, they first sit up, then they get out to the edge of the bed, then they kind of slowly stand, stay next to the bed, don't walk away. And I tell them maybe for 5-10 seconds or so, if that's their pattern, before they really feel that it's safe for them to continue walking.
Yeah, and that probably differs a little bit in everybody. It may take somebody 5 seconds, it may take somebody 20 seconds. What happens if it never goes away? If they stand up and they feel like they're going to pass out because they feel lightheaded and they have to lie back down?
Yeah, that's always significant, and everybody that has that, we obviously are going to evaluate them. The majority of those people, we probably will find that their blood pressure drops, and then the issue is why. And we're always looking, because that implies, neurologists are always looking, is it a global problem to both sides of the brain, or is it just one-sided? This is just TIA, these trans-ischemic attacks. And people that are dizzy doesn't localize when you stand up. It's a global phenomenon that implies the brain just isn't getting enough blood oxygen. And that group of people then really needs a full evaluation of what's going on. Medication. Is there underlying poor cardiac function? Are they anemic? Is there sludging of their blood? Is there something that's interfering with that blood flow? Now, the public often thinks it's going to be due to bilateral carotid artery disease, but it usually is not. Usually, even if there's carotid artery disease, the cause is really much more cardiovascular.
If somebody has anemia, low blood count, can they get orthostasis? They stand up and they get lightheaded?
Absolutely.
How about when somebody is in heart failure, or are there times where the heart can actually not beat regular properly, where people feel lightheaded?
Absolutely.
People with low blood sugar that have diabetes that take too much insulin, can they be lightheaded?
Yes, and with the diabetic, depending on how long they've had it and whether or not they have what we call dysautonomia, they may not have the typical symptoms of low blood sugar affecting their thought process and get confused. You may just see it as orthostasis. So there may be different sorts of manifestations of it. But it requires a thorough evaluation. This is something that we don't take lightly.
Yeah, and so when somebody has that feeling of lightheadedness and giddiness, I think what you're telling me is you really have to pay attention to what the patient says, and then you have to evaluate the different organ systems that can be involved, and almost anything can be involved.
Yes, and what drives our evaluation is, again, listening to the story And if I hear that story that happens when they first stand up and the lightheadedness, I'm not going to start with a vestibular workup looking for ear disease per se. I then am already directed in a different line of where I start, even to the point of doing a tilt table test, which is a whole different testing where people may have a drop in blood pressure, but the doctor can never record it. But they go into a cardiologist, they do a tilt table test where they're slowly elevating to a certain level. Over a period of time, the blood pressure may drop, and the cardiologist even gives medicine sometimes that may provoke it.
Vertigo, the room spinning, is that entirely different from lightheadedness?
It is. It's a...
And that's what we're going to be talking about when we come back. We're going to be talking about vertigo. What is the difference between lightheadedness and giddiness and true vertigo? What is it really is vertigo and what causes it? A lot of information. You're going to love this part. We're talking with Dr. Norm Walton, board-certified neurologist. We've been talking about lightheadedness and giddiness that can be due to a lot of problems going on with the heart, with the blood, with blood pressure, with medications. But now I want to switch to vertigo. What does vertigo mean? Norm, what is vertigo?
Vertigo, from my point of view, always means a sensation of movement and motion. And it doesn't make any difference if I feel that I'm moving or if the environment's moving. There's a sensation of movement. And then not only do we listen to the sensation of movement, but the type of movement. The more we hear that is spinning, I'm thinking anatomically, is it the semicircular canals? If I hear the symptom that they're being pulled forward or backwards, maybe to the side, to the ground, I'm thinking a little bit different mechanism because there's other parts of the inner ear, utricle, sacral, that are involved in that, but they're all tied up in this sensation of movement. Whenever we hear this, it always requires an evaluation.
So you mentioned inner ear. What are some of the causes of vertigo? And I'm walking toward the inner ear problem. What causes vertigo in the inner ear?
Yeah. Because it's the inner ear, what we do, again, we look at the anatomy. And that means it's an issue with the structures that are in the inner ear. And the two main structures are going to be the balance center and the hearing with the cochlea. And from a neurologic point of view, there's two separate nerves, the vestibular nerve and the auditory nerve. So when we talk about inner ear problems, that puts the disease process not in the brain or the brain stem, but within the ear itself, we're always listening for, are there auditory symptoms along with the spinning symptoms?
Okay, so the hearing would be the auditory nerve, and the spinning is the vestibular nerve. Is that correct?
Absolutely.
So what's going on?
Well, there can be dysfunction. Sometimes both can be affected. Sometimes it's separate, but it can still be an ear problem. When both of them are affected, then we have to listen to the story again. Did all this with hearing impairment as well as vertigo occur after a viral infection? If it did, we're thinking more a labyrinthitis.
Now, what's labyrinthitis? Does that mean it's in the same area?
Yes, because a labyrinth is a physical structure that contains the cochlea, the vestibular, as well as the beginning of the nerve. So that's a term that we use. But we also know some people may have a viral infection that only affects the vestibular part. We call that acute vestibulitis.
What's that like?
Well, that's all the terrible vertigo, nausea, and vomiting. It may last 2 weeks, 3 weeks, 4 weeks. People can be absolutely miserable with it. Typically viral. There's no specific treatment to cure it, but we try to treat the symptoms. And people are going to be very, very dizzy, vertiginous, spinning, no matter what they do, whether they're lying, they're moving. It occurs all the time. And early on, a lot of nausea and vomiting with it.
Is that a common symptom?
For acute vestibulitis is very, very common. But again, we're always looking for the story, are there any other symptoms with it? Because occasionally with just acute vestibular disease, it can be the first presentation of multiple sclerosis. But if it's acute vestibulitis from viral, typically monophasic, meaning one time. But if somebody starts having a second episode, separation, everything gets okay, third episode, then we're saying this person needs a further workup.
How do you treat acute labyrinthitis?
Many times this can be a bacterial infection. A lot of times illnesses that you may see with acute sinusitis that then go on, develop after 7 to 10 days, they're not getting better, then they start having no pussy discharge and this and that. And so frequently antibiotics may be used for the acute labyrinthitis. For the acute just vestibulitis without auditory, antibiotics are probably not used as much.
Can you use motion sickness medications?
Sure can.
Dramamine, Marazine.
Absolutely.
And every medicine has its side effects. So when you take something, it may make you sleepy, and you have to go into all that with the patient.
Absolutely. It may help a little bit, but it usually runs its course.
What's benign positional vertigo?
This is, again, where the history becomes very important. As I said, with acute vestibulitis, they have the nausea, vomiting, and vertigo. Well, the people with benign positional vertigo also have those 3 symptoms, but it only occurs when they get their head into a certain position. We have a way, neurologically, as well as ENT doctors, of putting the people in these different head-hanging positions. We then look at their eyes. They frequently have a type of motion that's very characteristic of it, and based on the history of no auditory symptoms, only occurs with position, doesn't occur in every position. With the eye findings, we can say this is benign, and it's benign from the point of view that it's not due to a stroke, not due to cancer, not due to a tumor, not due to an infection, but it's not benign to the patient.
Not at all. There is an Epley maneuver,
Yes.
Which does something to something in the semicircular canals. I'm going to let you teach me what that is.
Yeah, absolutely. They have, there's just some therapists that have unbelievably great skills. These canals are oriented in different directions. And what they do is that they can tell by eye movement and some of the other problems which canal they think is causing the trouble. And the theory is there's a little stone in one of those canals. So what they do is position your head in different positions, and as crazy as it sounds, they're actually draining the stone out of the canal into kind of a drainage area, and it can be absolutely dramatic how much better people are after they've gone through these vestibular rehab procedures like the Epley maneuver, and they have other names they call them too.
It's amazing to see people respond to those. We've got 2 minutes. Let's go into Meniere's disease. People hear about Meniere's disease. It's involved in the same area.
Sure.
Tell me about Meniere's disease.
Sure. Again, the history is everything. With Meniere's disease, you are going to now have the auditory along with the vestibular. But the difference is with the auditory, there's frequently tinnitus or tinnitus, and you can have that even with the vestibulitis. But the hallmark of the vertigo with Meniere's is that they have spells of it. It comes on out of the blue. Typically lasts for 3 or 4 hours, and they're as sick as can be with nausea and vomiting. Fortunately, the vertigo goes away after a few hours, and it doesn't make any difference what position their head is in. So it is a recurrent condition. The hearing loss can be
So there is
progressive.
hearing loss with it.
Yes, and usually low frequency, which is kind of the opposite of what people like you and I get with high frequency, and tinnitus, along with it too.
And what is tinnitus or tinnitus?
Well,
Either
tinnitus,
one.
again, anytime a nerve is injured, we think of a nerve as a transmitter. When it gets injured, it becomes a generator. So it generates its own signal, and that's the cause of numbness and tingling in your feet or burning. But in the auditory nerve, we refer to as that noise the nerve is so-called making is tinnitus or tinnitus.
Certain kind of noise? Is it more of a blowing noise or a tingling noise? Or
You just have to ask the patient. And
They all get different noises, don't they?
Everybody tells you something different.
Treatment for Meniere's and for benign positional vertigo?
There is treatment. It's entirely different than the benign positional vertigo because you can go through all the head-hanging positions. It's going to do nothing for them. But with Meniere's, the first treatment is get them on a low-salt diet. And this is really a low sodium because salt and sodium, as you well know, are 2 different things. So they have to be on a low sodium diet, frequently at least no more than 2 grams a day, maybe even a little bit less, 1,500. Want to make sure they're drinking plenty of fluid so they're not getting dehydrated and then get dizzy when they stand up, and frequently a diuretic. And there's many people with this, with Meniere's, that will have a fairly good response.
When people have vertigo, You and I were talking earlier, and we've only got 30 seconds. We need another 5 minutes. Tell me about walking and feeling unstable from the feet standpoint versus the head standpoint.
Yeah, there's a whole group of people that they use the term they're dizzy, and when you ask them, are you dizzy in the head or dizzy in the feet, what they'll say is, I'm dizzy in the feet. And when they say that, you say, well, are you dizzy when you roll over in bed? They'll say no, because rolling over is usually vertigo. They're only dizzy when they get up and walk, whereas the group that we initially talked about are dizzy when they stand up. These are dizzy while they're walking. And that can be any problem with the central nervous system, typically a peripheral neuropathy, a balance problem, and these people are very unsteady. And this is part of what neurologists do, is sorting out where in the nervous system is a problem arising.
And the key to sorting it out is listening to the patient.
Listening to the patient and then doing a focused exam and getting regimented and disciplined so we don't leave things out.
Norm, I'll have to say that I've watched you teach residents at the university, and one of the delights in my life is watching you teach, and it's been a delight watching you teach on the Dr. Bob Show. Thank you so much for coming.
Thank you.
Norm Walton is a great teacher. If you're going to want to stay tuned, we're going to talk about how the immune system can help fight off cancer. You may have had cancer 3 or 4 times this year, and your immune system is taking care of it. What happens if the immune system doesn't take care of it? And red blood cells, what's their function? A lot more information for you. I want to thank Dr. Norm Walton. Wonderful discussion on the difference between lightheadedness, giddiness, and vertigo. If you have those symptoms and they persist, be sure that you get it evaluated. And now questions from you, the viewer, that I think will be important to your health. Question number 1, Dr. Bob, how does the immune system work when somebody has cancer? Well, it's very, very exciting. The immune system is made to fight off diseases and to protect the body. You and I may have had cancer 2 or 3 times this year, not knowing it, because every cancer has its personality. We call it like an antigen on top of the tumor. The body, the immune system, recognizes that as abnormal, builds up antibodies. The antibodies against that tumor will bring in cells that dissolve that tumor. They're called natural killer cells, and they will kill a cancer that we may develop during the year. Now, there are certain things that make the immune system not be strong enough to protect against cancer, and then we get the rapid growth of cells. What's going on with the immune system now, though, is we're beginning to be able to train some of those cells, those natural killer cells, to work against certain tumors. So we'll be able to produce those, to inject them into the body. They'll find the tumor, and then they'll be able to dissolve the tumor. That's brand new stuff that's in its research right now, but it won't be long before we have that. There are other monoclonal antibodies. That's a big, long word. But every tumor has its personality, antigenic areas. We can develop antibodies that and send medicines to that area with monoclonal antibodies. Or the monoclonal antibodies will step in and stop the process of the tumor growing. Know that research will get rid of cancer, and we hope it will be soon. Question number 2. Dr. Bob, well, what is the purpose of red blood cells? Well, the red blood cells make us look red and rosy, and our lips rosy, and our fingernails give color. But what really the red blood cells do, they have a substance called hemoglobin. And hemoglobin will allow oxygen that we get when we breathe in from the lungs to attach to the red blood cells. And then the red blood cells go out to the rest of the body where they nourish the body. So we've got to have good red blood cells in order to be able to carry oxygen to the rest of the body. When the hemoglobin releases the oxygen, it will grab on to carbon dioxide, bring it back to the lungs where we breathe it out. Now, what can go wrong with red blood cells? Well, number 1, we can lose red blood cells. We can be anemic, we lose too many either by a GI bleed, from menstrual bleeding, from bleeding from the nose. Anytime that we have nosebleeds, we can lose some of the red blood cells that we need. There are some defects in red blood cells. If there's not enough iron or vitamin B12, then the red blood cells change their personality, and they change their thickness, and they change their size, where they don't deliver enough oxygen. So we can have anemia that can cause that, hemorrhage that can cause that, and there are some hereditary diseases like sickle cell. So anytime the red blood cell's abnormal, not going to carry enough oxygen around. The red blood cells are so important. The symptoms of anemia: shortness of breath, fatigue, don't feel good, weak. All the time that we have for this show. Remember, exercise, need to do it every day. It's the best thing you can do. Get 7.5 hours of sleep. It'll make you feel wonderful. Eat properly. When you eat properly, the body performs properly. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. I can't emphasize how important laughter is. Find that some person that you love, that you can tell funny stories with, that you can laugh and you can giggle and you can have a good time. Everybody else around you will also be happy, and you'll all be healthier.